glad to be here with you. I'm Karen Simonton, and I'm the Strategic Alliance Director for the Ortho Forum Value Network, which is the largest musculoskeletal network led fully by independent physicians. So definitely a pillar of connection between our group and FMMA. And I'm going to moderate today, really. I'm going to speak a little bit about what we do, but I'm really going to spend most of my time asking questions of Matt Ohrt, who you met yesterday, who is the Chief Healthcare Officer for Self-Fund Health. Mm-hmm. And Mike Havig, who you met this morning and maybe at other points during the conference, who is the founder and physician leader for HealthMe, as well as being an orthopedic surgeon and part of a musculoskeletal group that is part of the Ortho Forum Value Network. So thank you so much. I'm honored to be here today. I'll just spend a beat telling you a little bit about Ortho Forum Value Network and how I actually came to be part of this. So McBride Orthopedic Hospital, which is a member of the Ortho Forum, which will soon be celebrating its 25th anniversary, actually has been working with Jay Kempton for a long, long time. So shout out to Kempton, who's done great work with them, both internally for their own health plan, but also externally as they serve the community. And they introduced me to, McBride introduced me to Kempton introduced me to FMMA, both of those folks introduced me to Coral. And so what we're doing in the next several months is we are working with Coral and with Health Rosetta and with Mike Patton and Colton and Iowa and Bryce and so many of the really innovative benefit plan advisors across the country to lift community health plans in about 20 large MSAs. So we're really excited about that work. Additionally, our members are working with folks like Matt to lift FMMA chapters or to participate in FMMA chapters that exist across the country to bring employers, benefit plan advisors, TPAs, care navigation companies into one place to run town halls and to really do some of the education that is critical to the movement. And so we're excited about that. And I would be remiss at not mentioning the fact that Mike Havig and his team at HealthMe have been instrumental in helping our groups do the detailed work to get an understanding of what it means to lift pricing, bundles particularly, and then to collaborate with other marketplaces so that those bundles that may exist on a website for a group actually can also exist in other virtual marketplaces for employers and TPAs. So, having said all of that, Matt, I will turn things over to you for an introduction.
Yeah, it's great to be here with you. Just a quick question. So this says 4 minutes, is that right? That's really fast. There we go, okay. So I co-founded Self-Fund Health in April of last year. And so I kind of wear different hats across the state, but my role, Self-Fund Health is a start to finish, easy button, high performing self-funded plan. There's so much complexity and so many things to learn and so many things to do so we do that for employers. So as I built the healthcare story with Merrill Steele, now I'm helping employers across the state build it. But my role is interesting in that it's one to really move the movement, if you will. So to drive the movement in Wisconsin, which is actually really exciting and really working well. I'll talk more about that. We believe that even if it happens to be a competitor, which I'm not sure there's anybody doing exactly what we're doing, but if they happen to compete with us in some way, my role is to support them. My role is to show that a rising tide raises all ships. And we've got maybe how many slices in a pie? 12 slices. We don't need to be fighting over the one slice. We need to move the movement forward. And so that's my role, to be a Barnabas, to be an encourager, and to lift up doctors who are wanting to go independent, and employers who need to learn, and employers who are wanting to do more, and brokers who we work through only. So we work through brokers on the self-fund health side, and to educate them and to get, to find out who's interested and to get them going in the right direction as well. And to promote, to say that this is unsustainable, right? Several have talked about that we're going to have to change something. People don't generally change until they have to, but I think we have to now.
Dr. Havig?
Yeah, so I'm an orthopedic surgeon and practice in Florida. And been a member of the FMMA for just a few years. This is my first time attending the meeting, which is amazing. And so thanks everyone for having me. And it's really empowering for me, honestly, because you feel like you're in a silo doing this in your local communities. And especially as a specialist, trying to do direct pay and transparent pricing. And so it's really empowering to come here and hear all these great talks and feel you're part of the kind of the movement, if you will, the force. So thank you everyone for all the great information. But I started down this path in my local community. I practice in my hometown, so a lot of my friends that I grew up with are small business owners, and those of you who were at my talk earlier heard this, so I won't go into detail. But the bottom line is I learned I was turning them away. I didn't know I was, but my staff was turning these folks away, anyone that wanted to pay cash. And they told the patients, I only take insurance. And that couldn't have been farther from the truth. We had a piece of paper with self-pay pricing, like a lot of people do, somewhere on a desk. But the bottom line is the staff couldn't accommodate that. And we found that the most specialists around the country, I think our primary care colleagues are much better at this. But in orthopedics, we found that really it was actually almost 98% of large, sophisticated orthopedic practices were turning away direct payers. And so I wasn't the only one doing it. So we set out to solve that problem by helping bundle our services first, and then get fair pricing on those bundles, and then bring them to the local communities where the same patients that are seeing direct pay physicians can now get access to specialist care. So that's kind of been my mission over the last number of years. And like I said, I'm really excited to be here, and thanks for the letting me be part of the force, I guess. At any rate, thanks.
There's been such an emphasis during this meeting about education and how much of this really has to be directed towards education and equipping the community and in all of its parts and pieces with that. And so, Matt, I'd like you to talk a little bit about the organization that you are leading there in Wisconsin.
Yeah, so I became an FMMA chapter leader last year. I think I was kind of playing the role anyway for many years, so I thought, why not be formal, make it formal. So I joined Dr. Brian Erdman in doing that. But when I was at Merrill Steel building that story, I had started, we collected a few employers in roughly something like 2017 or 18, and we called it the Healthcare Best Practice Group. And it was very informal, and it was employers only. We said, let's just gather every so often and let's talk about best practices. As the story got out, people were starting to ask me a lot of questions, so I thought this would be a good way to share it. And so really just the networking, just like we see here, there's so much power in networking and building a coalition, if you will. So I started doing that. And so I think our first meeting, we had 2 or 3, and then COVID hit, and then it was stalled. But I persisted at that. And if anyone would like to be on that list, by the way, send me an email. It's kind of Wisconsin focused now, but it's really matt@selffundhealth.com. So if you're interested, it's no obligations, no fees, maybe 1 email a month. But we just started gathering all the kindred spirits, all the like-minded people. And today, so it's interesting how fast it's growing, because every time I send a number, like when I registered to speak, I sent Chris, or I registered 850. Chris said 850 yesterday. We're approaching 1,000, and that was like a month and a half ago. So there's a lot of people interested, and it's gathering the troops and saying, let's go, and education. So getting to education, that's our focus. A lot of people have approached me and said, how'd you do that at Merrill Steel? Tell me how you did that, or what's your strategy, or how do you win? And then I'll sometimes, it goes through my mind. It's like, oh my goodness, I don't, if this person is new to this, like I was maybe 8 or 9 years ago, my first thought is, what are you doing for the next 4 hours, right? Like I can't do this over a beer. I'd love to. So it's right. So it's like, okay, so we said, okay, we got to educate before we can really dig into the deep discussion. So we started doing, we call them employer events, but then we realized it's employer-sponsored healthcare. Everybody who swims in that pond. So now it's brokers, providers, et cetera, DPCs. But it started out with just employers. And so, in realizing we can't win unless everybody's in this game. And so we do free events. And we did 6 last year, Green Bay, Central. We cover the whole state. We've done 1 this year. We're drawing around 100 people. It's typically sometimes a day, but like 8 to 12 in the morning has been our latest. And then we'll put employer success stories on stage that can be inspiring. Although we're running out of those because, as I kind of indicated yesterday, show of hands, right? So we're building about 5 or so in the state. We have 6 prominent ones. So we're having to get creative in terms of how we do this. But education is maybe the first objective in moving the movement in Wisconsin and beyond.
I agree with that. And to that point, Dr. Havig, you have to educate and equip physicians for a brave new world, which is frightening for most of them to just think about how do you get out of the charge master and the allowables and the contract provisions, which may make them feel uncomfortable with being visible. So how do you do that?
Well, that's true. I mean, when I started doing this, interestingly, some of my partners even thought it might be illegal, right, to publish pricing. And that wasn't, I thought that was kind of crazy, but we actually had a healthcare attorney look into it for us because they were worried I was putting the group at risk. And subsequently, I get those questions often. And as someone I think alluded to yesterday, we're kind of, as physicians, addicted to the kind of insurance game and CPT and ICD codes and the works. And it is hard to get people to break that habit. But I think with the frustration we've heard from some of the physicians on the stage earlier about where healthcare system's gone, I think there's a critical mass of frustration, honestly, with, which has catalyzed this movement for the DPC docs and kind of what I like to call it myself as a DSC doc, direct specialty care. And so it's a little easier than it was a few years ago, but having people kind of just get out of their heads that you don't need codes, you don't need to send an invoice, at least if you're dealing with local direct payers. Now with the healthcare, the self-funded employers and the whole ecosystem there, I mean, one of the biggest challenges that I've had is I set out to solve this problem for local cash payers, right? The same group that a lot of DPC docs treat. And when you go into the self-funded world, all the mechanisms that serve the commercial insurance market and the coding and the forms, actually we have to step back in time and take a very simple solution that we're doing with direct payers in local markets and actually complicate the situation to fit into that mold. So I guess one thing I'd say to those in the audience who are part of the ecosystem is, can we break you of your addiction to forms and CPT codes and invoices and repricing and just kind of go directly, right? Here's the price, there's a provider, we have a buyer, a seller. Let's just simplify things. So that would be my wish, I guess. So when I come next year, we'll maybe have more of that. So hopefully.
And you are working on a network solution too, so that there's visibility, or there will be visibility.
Yeah, that's true. So I mean, we started serving the local population, which is still really what most of our practices do. Most of my specialty colleagues are amazed when they see how much of this business exists in their local markets. And their DPC colleagues can refer patients now to them without the headaches we heard yesterday from Jay in his opening talk about the experience he had at the hospital. That's the experience most people get in every doctor's office, honestly. And so by combating that locally, we've actually have about 1,500 orthopedic surgeons nationally that work with us and that we've helped kind of lift pricing transparency along with their surgery centers and physical therapy and imaging. And so we do have a tool. And the great part of this meeting, someone mentioned it, I think earlier, is the collaboration. So, I'm hoping, I've met a lot of great people here, and if anybody out there needs more providers who are offering this service, I can help partner with you to get those folks in front of their patients in their local markets, basically. So.
And for those of you that are actually running medical practices, all of this technology that is really new to many medical practice groups, shouldn't be, it's not new to the market, it's new to our market. It does actually help with staffing. So many of our groups are suffering with retention issues and having people to work the front desk and to manage those things. And so another technology solution. And Matt, in terms of network effects, I think that's probably, when you said, do you have 4 hours, that's part of what brought you to writing a book. Right.
Yeah, I think as we look around and we try to get educated, right? This is a great way to do it, and it's a lot of that's just missing, right? You learn a lot from discussions. That's how I learned, and a lot of it through experience. But hopefully that book can be a spark for others to write books and others to do things, and it's sorely needed right now, I think.
Yeah. And how are you working with the benefit plan advisors, that community of people? Because I know that's a part of what you're doing.
Right. Yeah, I think as I kind of kind of draw the line, if you will, right, with brokers. So at first, I'm pretty open and direct. I have a lot of broker friends, so it's not personal, but pretty open and direct. And I think in the book describe, right, kind of traditional brokers and then more forward-thinking brokers and what you need to do to be on that side. And a lot of that's compensation alignment. A lot of that's probably stuff you inherited, so don't fault you for that. But change that comp structure so that you're working, you got to either be working for the employer or you got to be working for the industry. I'm not sure you can do both. And align it. So, right, what I found is that this is the way it's just kind of happened. This is the tradition, if you will, right? So brokers are set up in their comp structure. What do they care about most? It seems to me book of business. That seems to be the focus, and that's what you've been handed. And so I commend you for being here, and I commend you for all the work you're doing. We're seeing a change in Wisconsin. What the broker needs to be rewarded for is planned performance. And that's been ignored. So because if the compensation isn't aligned, say it goes up 10%, that might be low for what we're hearing in Wisconsin in a renewal, all right, an increase for the year. The broker just got a raise on commissions while the employer and the employees, the payers, go home frustrated again. And so we talked about enrollment meetings. I don't know what your experience with enrollment meetings is, but they're ready to throw tomatoes when in my past when you walk in. And so that's not fair. That's not a win-win, and that's not the golden rule, and that's not looking out for others. What I told them at Merrill Steel, I said, I'm going to get up in front of you every year, and I'm going to work my tail off during the year to fix this for you. And I said, I'm going to get up and I'll tell you if it's bad news, I'll tell you if it's bad news. If it's good news, I'll tell you it's good news. But I'm not going to put the broker up here. I mean, they'll be here to support and they'll have a piece. They're on our team, but I'm not going to hide behind them. And so we got up and we did first year premium free, second year premium reduction, I think it was second or third, but we froze it. I think they're on their 7th year now of premium freezes. Then you start to have, right, you make healthcare a positive topic in your company. Right now, it's not in almost all cases. Yes.
So when a benefit plan advisor comes to you and says, I'd like to work with you, how are you equipping them to actually do the work, this type of work?
I think the book would be a good start. Education is a focus. I'll spend hours with them on a virtual or meeting with them if I need to get them aligned. It doesn't bother me a bit, by the way, if a broker doesn't know what to do. We'll teach them. I'll spend hours with them. We'll teach them as long as they have an open mind and they want to do the right thing. That's the kind of folks I look for. I don't pick on anybody for not knowing. I pick on them for perpetuating, bad, misaligned incentives and things like that. So, yeah, absolutely willing to teach. And if people are willing to learn and have the right attitude, that's when we'll be on the right track, and that's where the free market will really be opened up.
And Dr. Havig, you made a comment this morning, which I really wanted to spend a minute on, and that was how much primary care, musculoskeletal care is done in what was traditionally called an orthopedic office. We try to use the word musculoskeletal health care. Most of you say MSK because no one can spell that word or say it. But, I mean, talk to us about just the primary care, MSK care that's done in those offices.
Well, I think, I think a lot of physicians, we've been our own worst enemy to some degree, particularly our specialists. I think, basically a lot of folks, we try and limit the patients we see, number one. I think we're the only business that tries to find ways to keep patients out of the office. My colleagues say, I don't want to see this or I don't want to see that. I only see, knees or whatever. But to Karen's point, we've also, we're surgeons, that's in our name, and I think an orthopedic surgeon, we're all kind of proud of that. There's some sort of whatever about it. But we're really, I looked at my numbers, about 8% of the patients that come to my office end up having surgery, and I think the national average is about 1 in 10. So 90% of the people that come through the office and are seen are treated without surgery, right? They need physical therapy, they need rest ice, anti-inflammatories, they just need advice and they need care provided to them. And I think that we've been left behind in some of these movements because we are portrayed as kind of the boogeyman that you go and see a surgeon, you're gonna get surgery, right? But the numbers would say otherwise, but we don't do a good job of promoting ourselves as such. So I think that's one of the other messages I tell my colleagues. It's like, look, something like in the ages 19 to 64, I think 30% of the employer spend, roughly a third I've seen, is on musculoskeletal care. and that's been farmed out to digital first companies, which are great. I think that's the wave of the future. It's going to be digital first. It's going to be brick and mortar as needed, and then maybe back to digital. But here's the deal: if you're a plan builder and you're paying $1,000 to engage a digital first physical therapy solution, for example, and that company has told you it costs $5,000 if you go to the orthopedist's office. Most of our clients that I've helped bundle and price their services, you can get an in-person office visit with a board-certified orthopedic musculoskeletal provider, surgeon. I'll try not to use that word. You can get 6 physical therapy visits in person, and the average nationally to do that is about $800. So we're coming in at $200 less than some of the big digital-first musculoskeletal health coaching and physical therapy providers do. But again, we're not good at promoting that. So that's one other message I'd like to get out. If you are a plan builder, broker, advisor, and can find orthopedic surgeons, and I can help you here, that offer transparently priced digital care, not just surgeries, which everybody focuses on. Everyone here is surgery, surgery, surgery. Most of what we do isn't surgery. And so I require anyone working with us on these bundles to offer office visits, and because that's where 90% of the care is. And we can do it cheaper than some of the big digital first companies who are selling you a point solution with a dead end if they need escalation of care. Then you're starting all over. Now you spend $1,000, and now you got to get wrapped back in the care cycle, starting with other things that will cost money. So at any rate, again, I'm trying to encourage my clients and my colleagues to offer the whole spectrum of bundled care, not just surgeries. And I think we can do a better, I promote it myself, but I got to get my colleagues on the same train, but they're getting there slowly. So anyway.
Yeah, and to that point, again, I think I mentioned that Dr. Havig's group is part of Ortho Connect and part of the Ortho Forum Value Network, and that group of people is really focused on patient-reported outcomes, net promoter scores, things that actually speak to the patient experience, both in a qualitative way, but also in an experiential way. And so that's also part of this. And to that end, we have contracted and partnered with Embold Health. Many of you will know that name from Walmart. Daniel Stein built that company. And the Ortho Forum Value Network partners with them because that data, that quality data that's coming out of claims information on 3 different criteria, appropriateness, effectiveness, and cost, is being sold to Walmart and used for steerage and Microsoft and Dollar General and Blue Cross Blue Shield of Arkansas. And so we are looking at third parties to come in and help us also curate where we have remediation issues. And so that's great news. And I would also say that the very first time you and I met around this issue, it was because Bryce Heinbaugh was looking for a foot and ankle surgeon in somewhere around Miami. And so I spent Labor Day weekend trying to find the right person and ended up coming across HealthMe on, I think, Vero Beach's, I think it was their website. Yeah. So it's interesting. And then Ann Margaret, who's also a big FMMA fan, actually when she met Mike said, well, what I'm really interested in most is the walk-in off the street consult physical therapy bundles because it really just changed access.
Yeah, that's the thing. I mean, I think the access to care is a big issue, and just most people don't realize it. I mean, it's your friends and neighbors. That's what I tell my colleagues. These are people that live down the street from you. They're people that your kids play sports with, and they're trying to get in to see, and your staff's turning them away. So it is access, and it is, again, serving these local networks. I know here the focus tends to be on the self-funded plans, and that's very important, but there's really, I feel there's no reason anybody should get on an airplane to have health care, right? Because you should be able to get transparently priced, quality bundled health care in your region at least, right? In your state. Maybe you have to drive an hour or two, but the only reason people travel for health care, there's 2 reasons. One is for highly specialized care. You need specialized cancer care, things like that. You might get on the airplane and go to Johns Hopkins or MD Anderson or wherever you want to go, Mayo. But the main reason people travel for healthcare is for price. They're traveling for price, transparency, savings. That's why people travel. And I see people from all over my state that get referred, and that's great. I love having them as patients, but deep down, I feel a little bit guilty that these people have to get in their car or drive down to see me. But when I was talking to some of these patients, they're like, well, and I always say, are you okay driving across the state for your care and whatnot. They say, yeah, before you were doing this, they were putting us in airplanes, sending us to Texas. And then so I was like, okay, well, I guess it's great, but I'd love to get you care over in Miami or in Daytona or wherever you're from. So that's my mission, is try and get all my colleagues offering transparently priced, bundled quality, as Karen said, measurable quality, specifically bundled healthcare in their communities. And I think we all can step up to the plate and get that done. So.
Yeah. So Matt, for everyone who's sitting in this room also and saying, we as benefit plan advisors, specifically probably that group, have found it challenging to reach out to HR and for HR professionals really to embrace change and what might be a little frightening in terms of, we'll say some complexity, different complexity, sure. Different complexity. So how would you speak to that? Because you clearly are of that family of HR professionals, and you took responsibility and changed things.
Right. Yeah, I would say lots of complexity, right? Sometimes intentionally. So, I think one of the first steps, the longest chapter, I mentioned in the book, is the understanding the situation. Got to understand it before you can do anything about it and solve it effectively. But I, as an HR person for something like 23 years, I was probably a little different than my peers. And, it was always my fun, if you will. I use that word loosely, but it's to move needles and to help people and to make things better. So Dave Chase had talked about, I have this as a discussion within the book, HR people have maybe given two directives, and I would agree with this in some sense, even if it's not spoken. Keep people happy and don't get us sued, right? And it's not very inspiring. Maybe the happy part, but I would say 20 to 25 years of decline, right? While the employer plans are falling apart. Is that keeping them happy? Are enrollment meetings happy? I wouldn't call that happy at all. I'd say that's the opposite. So, sometimes fixing problems is what's needed. I view problems in a weird way. I grew up with the Toyota root cause problem-solving process, right, in my early career, and problems are an opportunity in disguise. When I look at every achievement or any resume bullet on, it always started with a big problem. And so healthcare is a big problem, so go after it. Get the right support from owners or CEOs or president, and you can be the hero. It's not easy. That change management journey can be tough, but get the bat off your shoulder and don't watch. I'm a two-strike swinger. I don't. I played baseball. I don't swing at bad pitches, but if you got the bat on your shoulder while the third pitch goes by, you're not, you're going to be sitting in your rocking chair with a lot of regrets, I think. So go after it. Do it the right way. Get educated, but go after it. Your people need you to go after it because they're suffering.
I love that. And I do love the whole concept of embracing challenges, embracing problems, and just knowing that it's a team of people who help you get things done. Absolutely.
Yeah.
So, questions from the audience for Dr. Havig or Matt? Any questions? Anything you'd like to tap on before we finish here? Anything that we didn't cover?
Nothing specific. One thing is, I think one of the things we're doing in Wisconsin, which is one of the worst states, and I think that is this movement part, right? This movement is about opening up the free market. This movement is about being able to shop employer plans, all the many 30 pieces or all the pieces that go into that, enabling your members to shop and overcoming all the roadblocks. But we go around. I had a friend, Ken Stremiska, told me, I've been asking people, what do you think makes a movement work? I've been researching movements and so this movement of healthcare, and he gave me great advice. He said, a movement is starting a bunch of grass fires in a lot of places. And, it's not necessarily one big fire in the center of the state, but it's going here and starting a grass fire. Maybe it's even just starting an individual grass fire or fire in someone's belly, right? I hope everyone's inspired as you leave here, and everywhere you go, start those grass fires and they spread, because the networking of people can do amazing things. We can't do it on our own. So we're going to have to get as many people involved, as many people educated and involved as possible, because that's when this is going to happen. This can't be a top-down deal. This has to be a grassroots effort.
Yeah, retellability yesterday was so good. Like, can you make your message so succinct and so powerful that when you drop it into a grass fire, that it actually spreads?
It spreads,
It
right.
spreads. And again, in this thing that we're trying to do, it is pretty complicated. And so getting it down to something that's distilled to powerful and repeatable is important. So how about you, Dr. Havig?
Yeah, I would agree. I mean, I think you got to get in the game. To stick with our sports analogies, we're both saying, when I talk to a lot of my colleagues, their hesitancy to do this is it's a radical change, number one, and people don't like change. They're willing to put their head down and suffer through the status quo, and we've heard that from a lot of the physicians up here, I think. But I think you need to start somewhere. That's an Ann Margaret McCraw saying, CEO of a practice that we work with. And that's what I say is you got to start somewhere, right? And you can start as a specialist by building bundles, transparently pricing, serving your local community. And then that will kind of spill into some of these bigger movements with the self-funded employers and whatnot. But, one of the biggest pushbacks I get is, I kind of alluded to it earlier when people were saying, is it illegal to do this? They're kind of afraid to put their price up. Interestingly, when they do put their price up, I think they take some responsibility for that price. So I would say by and large, physicians tend to put their prices up, like when they tell us, okay, this is what we want to charge for each of these bundles, they tend to underprice them actually compared to the market, which I think is just interesting. I thought it might be the opposite. They're going to give me their charge master price, which is some ridiculous price nobody's going to pay. They tend to underprice because you're holding to an account, and some people fear that a little bit. But what I tell them is, look, if you don't have a price up, the bat's on the shoulders, Matt said. I mean, you're not even in the game, honestly. You're not even in the stadium. So people say, well, if my price is not, consistent, or I'm a little higher than this other group down the street's price, how much business am I really going to get? And what I say is, look, you're not even in the stadium. If you don't have a price up, what are you getting? You're getting 0%, zero. If your price is a little higher than your competitors, so-called competitors, you might get 10%, maybe you get 50%, maybe you get 75%, but you don't know until you get in the game, stick with those. And it's kind of frustrating that it takes so much work to get people to do something that just seems common sense. So again, I'd encourage everyone in the audience, you're the DPC docs in the audience, I've talked to a lot of you over the week here, and encourage your colleagues, right? Call your specialist who you refer to. And I heard a lot of people say, well, I've got a friend and I text them and they get my patient in. I mean, I do that all the time for folks too, but it shouldn't even necessarily have to be that way. You should just be able to confidently say, this orthopedic group, this cardiology group, this urology group, they have transparent pricing right on their website. You can purchase a package there. So I would recommend Dr. Jones, Smith, whoever you want, but be able to recommend that patient or refer them with confidence that they're going to get a fair price and they're going to have good care. So as Matt said, the network, the community of all this, we can all work together to try and promote this in our communities. And it starts, in the community, it starts as a grass fire, and hopefully, it's spreading nationally thanks to groups like FMMA. So thank you.
Absolutely, absolutely. So any questions from the audience?
We got one right here.
Yes. He was asking if there was any pushback from carriers when when you've posted your prices. Are you getting any pushback from anybody else you might be participating with?
Yeah, so the worry is if you price a bundle at, say, $250 and maybe an insurer might pay you more for that bundle, or the insurer's going to get upset. But the advice I give people is basically, you want to be paired fairly as a physician. I think people conflate self-pay or direct pay with charity care. And so charity care, I think a lot of us will charge Medicare rates, which is great. And we still do that. I mean, it's not an all or none thing. We provide my group, myself, we provide a lot of charity care still. And generally we charge a Medicare rate for that, and we end up writing it off, right? It's not worth the effort to collect it, quite honestly. But most direct payers are not charity cases. And so people say, well, if I price these at Medicare, is my commercial contract 150% of Medicare? What's going to happen? And the answer is no, you price it similar to your best high volume commercial insurance contracts you're happy with. So you don't really undercut them. And I think the people in this room understand, and I think the brokers, advisors, and others, the physicians have to be reimbursed fairly. If you want good doctors taking care of your patients, you have to pay them. That doesn't mean you have to pay the charge master price. And I always tell people the delta that we're really exploiting on price here is the difference between what the hospital-owned facility is going to do and what you can do it for in your office or your surgery center. And that is a huge delta. And that's what payers are looking for. So the answer is no. One other comment on that is even if you did price below your commercial insurance rates, if you're, say, you're getting a crazy high commercial insurance rate, which I don't know anybody that does, but if you are, you're bundling all this care. So nobody has a contract with Blue Cross for a bundled office visit. They just don't. Nobody has, the bundled surgery packages, even surgery bundles, as they're commonly known, are like, well, we're gonna do rotator cuff, but it's gonna cost a little more if we do a bicep and a little more if we do this. And by the way, the implants we're gonna charge out for. So it's a bundle, but it's kind of a partial bundle. And so that case could take, could add this CPT or that CPT. And so an insurer, you're billing out for each of those codes. With a bundle, the bundles that I advocate for, they're all in, right? I mean, so you're taking the good with the bad as the surgeon, but there's really no bad. And we don't have time to go into that because you're going to price these where you're doing okay on the more complex cases and you're doing well on the simple cases, and all comes out in the wash. So, but great question.
Yeah, and we're out of CPT codes, which is great. I mean, it's a refreshing thing to sit down with the doctor and say, we're going to set our office visit bundles, and we don't care if they're 4s or 3s or 2s. So for those of you who are physicians in the audience, you clearly know what that means.
It's very liberating, actually.
It is very liberating, yes. There was a question over here.
Speaking of bundles, I found it challenging to get past the HR to decision makers in the business, because the dynamic there seems to be the business owner kind of transfers the knowledge and responsibility of healthcare to the HR. And the HR seems to be so overwhelmed by so many responsibilities that many bundle all their stuff together. So they have payroll, healthcare, all the ancillaries are all together, plus with a relationship with whoever sold them the bundle. And so to unbundle all that for a new thing is like a whole lifesaver. Like how do you bring in a lifesaver to that, or any suggestion you have to try to kind of to get in there? Because I really loved your comment that I personally want to work for the employer, the employees, and our patients, not the system. So that's how do you bring out the lifesaver in that kind of thing?
Yeah. I found when I've inherited teams, right, going into, lead HR for a company or something, 10 or 15, it's taken me 1 or 2 or 3 years to inspire and educate the HR team, and then they'll come alive. So, I mean, it's not right, they can, but I think if the question is getting HR to move, getting HR to, they're so busy. Recruiting is really tough right now, and they're spending most of their time on that. And how to recognize. I think companies can hire even a chief, whatever you want to call it, chief healthcare officer, right? And you can probably pay for that salary 10 times over, have them sit next to the HR VP and report to the CEO. There's an easy return on investment. So that's one idea. So you have a resource to do it. But this is a company's biggest opportunity. So I think you've got to get the CEO and the CFO involved. I mean, have you ever seen emails or requests, please take it easy on office supplies? They're high, or return the extra folders you have. Nothing wrong with that. To the storeroom, nothing wrong with that. But those are pennies. Or we're going to try and get 1% off a steel that we buy this year for our product. We're talking about not just the biggest HR opportunity, the biggest business opportunity. So we know we need to educate. You can do something about it. And this can be 20, 30, 40% off of your second or third highest cost. This is your biggest business opportunity. And so just things like that. But I think it's really... sometimes, if HR is too busy or just not getting it, maybe you can get them educated, but I think I would try to pull in others. I would go straight to the CEO or CFO and say, did you know that this is an amazing, and by the way, it'll help your recruiting. It'll make the recruiting part easier. So not easy. I mean, it's a great question, but then I think you've just got to go to someone else and get others involved and get others aware that I don't think the government's rushing in to fix this and at all, and we're going to have to do a grassroots fix here.
Yeah, and let's build some parties, because I think these town halls are great opportunities to have cocktails and have some appetizers, and in a very low-key way say healthcare is solved. We just have to dig it out. We just have to dig out the solution. So thank you so much for your time and attention, and welcome to the rest of your meeting.
All right.
Thank you, gentlemen.